It starts with the socks. You've probably seen it yourself. That moment at the end of the day when you peel them off and your skin doesn't just bounce back. Instead, a deep groove remains, a perfect canyon tracing the elastic band, a testament to a pressure that seems to come from within. For Arnold, a man in his late 70s, this was the first sign. He'd sit on the edge of his bed, the evening light filtering through the blinds, and just stare at those twin indentations on his shins. He'd press a thumb into the swollen flesh next to them and watch as the white pit lingered for an uncomfortably long time before slowly, reluctantly refilling. At first, he had a dozen explanations. It was the heat, it was the salt from the canned soup he'd had for lunch. It was just gravity, he'd tell himself, the inevitable pull of the earth on a body that had been standing on it for nearly 8 decades. He'd dismiss it with a wave of his hand, a quiet conversation with himself that always ended with the same conclusion. It's just part of getting old. But lately, the signs were becoming harder to ignore. It wasn't just the swelling anymore. The skin itself was changing. He'd run his hand over his shin and feel a strange tightness, a waxy, fragile texture, as if the skin were a thin piece of parchment stretched to its limit. It had a shine to it now, a glossy sheen under the lamplight that made it look unnatural, almost artificial. And then there was the color. A faint, blotchy, brownish tint was creeping up from his ankles, like a permanent stain seeping up from the ground. He'd noticed it months ago, but had chalked it up to a long-forgotten bruise. Now, it was undeniable. It was a map of something happening deep beneath the surface, a story his body was trying to tell him in a language he didn't understand. The most troubling part wasn't how his legs looked, but how they felt. Heavy. That was the only word for it. They felt like anchors, waterlogged and burdensome, requiring a conscious effort to lift with each step. Walking up the stairs to his bedroom had become a negotiation. The short walk to the mailbox felt like a journey. He found himself sitting more, not out of laziness, but out of a profound, bone-deep fatigue that seemed to emanate from his lower legs and spread through his entire body. He'd catch his reflection in a shop window and see not the vibrant man he still felt he was inside, but a stranger who was slowing down, a man being weighed down by his own body. The dismissal, the easy rationalizations were beginning to fail him. That quiet voice in his head that said, "It's just getting old," was now being drowned out by a louder, more insistent whisper. "This isn't right." This quiet moment of worry, sitting on the edge of the bed, looking at the roadmap of problems on his own 2 legs, was the beginning. It was the moment the vague unease crystallized into a decision to seek help. This is the start of Arnold's journey. Not just a journey to find a diagnosis, but a journey into the heart of the modern medical system itself. And what he was about to discover is that the most obvious clues are often the ones the system is least equipped to see. This single visible sign on his legs was a warning from his heart, but it would soon be lost in a sea of tests, numbers, and procedures that looked everywhere but at the man sitting right there in front of them. "I'm Dr. Is that Dean?" And that feeling of uncertainty Arnold is experiencing, that dawning realization that your own body is sending you a message you can't decipher, is a feeling I've seen in my patients thousands of times. It's a vulnerable place to be, standing at the edge of a medical system that can feel vast, impersonal, and confusing. You have questions, you have fears, but you don't always know how to ask the right questions, or even who to trust with those fears. That is why this channel exists. My mission here at Keystone Health is to bridge that gap. It's to take the power that is shifted towards complex tests and abstract numbers and place it back where it belongs, in your hands. We are here to empower you to navigate your health after 60 with confidence, armed not with fear, but with evidence. Our entire focus is on a simple yet revolutionary idea that the ultimate goal of medicine shouldn't just be to extend your lifespan, but to enhance your quality of life. Too often, patients like Arnold are put on a conveyor belt of automatic screenings and procedures, managed by well-intentioned doctors who are themselves trapped in a system that rewards action over observation and intervention over wisdom. My promise to you is to cut through that noise. I will translate the dense language of clinical trials and medical guidelines into clear, actionable knowledge that you can use to have more meaningful conversations with your own doctor. We will look at the evidence together, and I will help you build a framework for making decisions that truly align with your values and your goals for the years ahead. But to do that, we have to start by confronting a very difficult and uncomfortable truth about the nature of modern medicine itself. What if I told you that the very system designed to find problems is often blind to the most obvious ones? It's one of the great unspoken paradoxes of healthcare today. We have more technology, more data, and more screening tests than at any point in human history, all aimed at detecting disease earlier than ever. And yet, this relentless focus on finding what might be wrong in the future can create a dangerous blind spot for what is clearly wrong in the present. The modern obsession with routine screening has in many ways created a powerful distraction. It encourages doctors, even the best and most well-intentioned ones, to spend more time looking at numbers on a chart than at the patient sitting in the chair. They are trained to hunt for shadows on a scan, for tiny deviations in a blood test, for risks that are years or even decades away. And in doing so, they can miss the clear physical signs the body's shouting at them. This is the central conflict in Arnold's story. His legs weren't just a cosmetic issue or a sign of getting old. They were a billboard, broadcasting a critical message directly from his failing heart. But the system he was about to enter wasn't primarily built to read that sign. It was built to run a checklist. It was primed to order a battery of tests for things he didn't have, while completely overlooking the one thing he did. The story of Arnold's legs is the story of how well-intentioned medicine can go profoundly wrong. It's a story of how our quest to find every potential future disease can lead us to ignore the one that is actually causing suffering right now. It's a quiet truth that the system doesn't like to talk about. The risk-to-benefit math of many routine tests changes dramatically as we get older. The potential for a test to cause harm through anxiety, unnecessary procedures, and life-altering complications begins to outweigh its potential to help. Medicine becomes less about healing and more about simply finding things, whether those things need to be found or not. Here is the path we are going to walk together in this video, and I want you to see it as a roadmap to taking back control. First, we will solve the initial mystery, what Arnold's legs were trying to tell him. We'll connect the dots between that tight, shiny skin, the persistent swelling, and the hidden mechanics of a struggling heart. This is the crucial clinical sign that the system, in its rush to screen for future problems, so often misses in the present. From there, we will broaden our view and dissect 5 of the most common medical screenings that, for many people over 60, can trigger that dangerous cascade effect. We'll look at each one, not to dismiss them entirely, but to understand the precise point when their risks begin to eclipse their benefits. We will look at the hard evidence from major clinical trials and hear the stories of how these routine checks can lead to a spiral of unnecessary anxiety and genuinely harmful interventions. And most importantly, after we've laid out the problem, I will give you a clear, practical solution. I'm going to equip you with the single most powerful tool you can have in these situations, a simple set of 5 questions to ask your doctor before agreeing to any test or treatment. These questions are designed to cut through the noise and recenter the entire conversation on what truly matters, your well-being and your quality of life. The 5 tests on this list are so deeply embedded in our idea of good health that some of them will almost certainly surprise you. But it's what they reveal about the system's priorities that is truly eye-opening. And as we go through this list, there are 2 tests in particular I need you to pay very close attention to. The third test we'll discuss is one that, on the surface, seems like the most logical step for someone like Arnold. It's a routine heart check. But the great tragic irony is that this very test, the one intended to protect his heart, is what led doctors further and further away from his actual heart problem, triggering a cascade that provided no benefit and caused significant harm. Then there's the 5th one. This test reveals a hidden surgical catch-22 that most patients, and frankly many doctors, don't fully appreciate until it's too late. It's a situation where the standard fix for what the test finds can be statistically riskier than doing nothing at all. The treatment itself can be more dangerous than the condition it's meant to prevent. You will want to hear that. These are the kinds of hidden traps that are woven into the fabric of the system. And that actually brings up a question I have for all of you watching. Before we dive into the evidence, I'd like you to pause for a moment and just let me know in the comments below. Have you ever felt that your doctor was more focused on your test results than on how you were actually feeling? There's no need to share any personal details. A simple yes is enough. The reason I ask is that this experience is at the very heart of the problem we're discussing today. It's that feeling of being misunderstood, of having your real, tangible symptoms, the things that affect your daily life, pushed aside in favor of a number on a lab report or a shadow on a scan. It can make you feel like you're not being heard, that you're just a collection of data points instead of a person. When you share your experience, you do two things. First, you help me and the rest of our team understand what you're truly facing. But more importantly, you show everyone else reading that they aren't alone. Seeing a wall of comments from people who have felt the exact same way is incredibly validating. It builds a community that understands this struggle. This systemic drift away from the patient and toward the paperwork is precisely why we need a new way to approach these decisions. To protect ourselves, we need a different filter to view every medical choice through. A framework that puts our actual lived experience back at the center of the conversation. So let's build that framework right now. I call it the longevity lens. It's a simple but profound shift in perspective. The longevity lens isn't about extending life at all costs, chasing every last possible year no matter the price. It asks us to view every single medical decision, every test, every pill, every procedure through one single clarifying filter. Will this improve my quality of life, both right now and in the meaningful years I have ahead? This question is the anchor. It forces us to weigh the definite burdens of a medical intervention, the side effects, the anxiety, the recovery time, against its often uncertain benefits. It moves the goalposts away from the system's obsession with normal numbers and back towards what actually matters to you, preserving your independence, your energy, your ability to enjoy your family, and your peace of mind. It acknowledges a crucial truth that after a certain age, the relentless pursuit of a perfect lab report can actively destroy the quality of the very life it's meant to protect. So for the rest of this video, this is the framework we will use. We will look at each of the 5 common tests through this longevity lens. And this lens itself is built upon a few core principles, a few fundamental truths about health as we age that the system often forgets. So the first principle of the longevity lens is this: you are increasingly likely to die with a condition rather than from it. Let that sink in for a moment. It's a profound shift in thinking. As our remaining time horizon shortens, the statistical probability that a slow-moving, newly discovered condition will actually have time to cause harm drops dramatically. Modern medicine has become incredibly good at finding things, but it's not always good at asking the next, most important question: does this thing we found actually matter? Think of it this way. Finding a spot of rust on the fender of a brand new car is a problem you need to address immediately because that car has a long road ahead of it. But finding that same spot of rust on a car with 300,000 miles on the odometer and worn-out engine, it's simply not the most pressing issue. Something else, like the engine or the transmission, is almost certainly going to end that car's journey long before the rust ever does. This is precisely the case for many slow-growing cancers or chronic conditions discovered late in life. Screening might find a low-grade prostate cancer in an 85-year-old man, but the evidence tells us he is far more likely to pass away from heart disease, a stroke, or pneumonia than from that particular cancer. Treating it, therefore, introduces all the risks of intervention: surgery, radiation, side effects, for no real survival benefit. It's like putting the car in the body shop for a cosmetic fix when the engine is sputtering. This principle reframes the goal. It shifts us away from the system's default setting of find and destroy everything and moves us towards a more discerning, wiser goal of find only what truly threatens my quality of life. This helps us decide what is worth looking for. But even when a test finds something that seems to matter, there's a second, crucial principle that determines the real cost of going after it. And that has everything to do with our body's changing ability to weather the storm of medical intervention. The second principle of the longevity lens is something we all understand intuitively as we get older. Our bodies simply have less bounce back. Our reserves are shallower. Our ability to recover from stress, whether it's an illness or a medical procedure, is diminished. This is the principle of reduced resilience. Think about the preparation for a routine colonoscopy. For a healthy 40-year-old, the aggressive bowel prep is an unpleasant, inconvenient 24 hours. They might feel weak or dehydrated, but within a day, they're back to normal. For an 82-year-old like Arnold, that same prep can be a genuinely dangerous event. The dehydration can lead to dizziness, a fall, and a broken hip. The electrolyte shifts can put a strain on the heart. What was a minor hurdle for the younger person becomes a potentially life-altering event for the older one. This same logic applies to everything. A new medication's side effects that a 50-year-old might push through can cause debilitating fatigue or confusion in an 80-year-old. The stress and anxiety of a biopsy, followed by a week of waiting for results, takes a much greater toll. The cost of every medical intervention is simply higher, paid for with our finite reserves of energy and resilience. This vulnerability, this reduced ability to absorb the blows of even well-intentioned medicine, is what makes the third and final principle so profoundly dangerous. Because when one small intervention causes a problem, the system's answer is always another intervention. This is how the first domino falls, setting off a chain reaction that can be nearly impossible to stop. This is the slippery slope, the one I call the Cascade Effect. Here's how it works. It starts with a routine screening, a test done just to be safe. This test flags a minor, ambiguous abnormality. A shadow on a scan, a number slightly outside the normal range. It's probably nothing, but now that it's been found, it can't be ignored. The medical legal system and a doctor's own training demand the next step. So a second, more invasive test is ordered to investigate. This test might require sedation or a contrast dye that's hard on the kidneys. It might in turn lead to a biopsy to get a definitive answer. Each step along this path carries its own small risk, but the momentum is building. The pressure to get to the bottom of it becomes immense. And then the complication happens. A minor infection from the biopsy, a bad reaction to the anesthesia. It's that 1 in 1,000 event that, due to reduced resilience, isn't minor at all. It leads to a hospital stay, which introduces the risk of delirium and muscle loss. A week later, you're discharged, but you're weaker, on 5 new medications, and your quality of life has taken a permanent hit. This is the Cascade Effect. It's a slippery slope where each individual step seems logical, but the cumulative journey leads to a place you never wanted to go. It's the system's momentum taking over, a chain reaction that is incredibly difficult to stop once it begins. And it's precisely the trap that Arnold is about to fall into, all because his doctor will soon be focused on a checklist of routine tests instead of the clear message his legs are sending. This cascade can be triggered by some of the most common, most routine checkups we're told are essential for good health. And the first one we need to examine through our new longevity lens is a test that millions of older adults undergo every year, often without fully understanding how it can start this very slide. So let's begin with our first test, the routine screening colonoscopy for adults over the age of 75. For decades, it has been a cornerstone of preventative health, and for good reason. In younger populations, it unequivocally saves lives. But when we view it through the longevity lens, the risk-benefit calculation begins to shift dramatically. The principle of reduced resilience comes into sharp focus. The aggressive bowel preparation can be a grueling, even dangerous ordeal for an older body, risking severe dehydration and falls. Then there's the principle of outliving the problem. A screening might find a slow-growing polyp that, in the remaining lifespan of an 80-year-old, would likely never have developed into a life-threatening cancer. Yet, finding it often triggers a removal procedure with its own set of risks. We start to see how the definite burden of the test can begin to outweigh the speculative benefit. We trade a certain loss of quality of life in the present for an uncertain gain in the future. The statistics are one thing, but the human cost of this one-size-fits-all approach is where the real story lies. And it's a story that played out quite dramatically for a vibrant woman named Margaret. Margaret was 78, but she'd be the first to tell you that number was just a suggestion. She lived alone, managed her own finances, and her garden was the envy of the neighborhood. Her weeks were full. Tuesdays were for her book club, Thursdays she volunteered at the local library, and weekends were for long, rambling walks with her rescue dog, Buster. Her independence wasn't just a circumstance, it was the core of her identity. It was the thing she valued most in the world. So when her doctor, during a routine checkup, said it was time for another colonoscopy, she didn't think much of it. He was a good doctor, and this was just part of the standard playbook for healthy aging. "We're just checking the boxes, Margaret," he'd said with a reassuring smile. "Better to be safe than sorry." She had no symptoms, no family history, no reason to be concerned. But she trusted him. She trusted the system. She picked up the prescription for the bowel prep kit and marked the date on her calendar. The ordeal began the afternoon before the procedure. The first glass of the gritty lemon-lime flavored liquid was unpleasant but manageable. The second was harder. By the third, her body was in open rebellion. The hours that followed blurred into a miserable cycle of cramping, nausea, and a desperate, draining urgency that chained her to the bathroom. Sleep was impossible. She felt her strength seeping away, replaced by a dizzying weakness she had never experienced before. Her body felt alien to her, fragile and hollowed out. Around 3 a.m., stumbling back from yet another trip to the bathroom, it happened. A wave of dizziness washed over her in the dark hallway. The floor seemed to tilt beneath her feet. She reached out for the wall, but her hand found only air. The fall wasn't dramatic. It was a heavy, crumpling thud that echoed in the silent house. For a long moment, she just lay there on the floor, the cold wood against her cheek, her heart hammering against her ribs. It wasn't the pain that scared her. It was the profound sense of helplessness. Here she was, the independent woman, the gardener, the volunteer, unable to get up off her own floor. She eventually managed to pull herself up, her body trembling, a deep, painful bruise already forming on her hip. She made it to the procedure the next morning, exhausted and shaken. The doctor was pleased. The result, after all that, was perfectly clean. "See?" he said, patting her hand in the recovery room. "Nothing to worry about."
"You're good for another 10 years.
But Margaret wasn't good. The harmless test had a steep price. The bruise on her hip took weeks to fade, a constant aching reminder of her fall. But the invisible wound was deeper. Her confidence was shattered. For the first time, she felt frail. She started second-guessing her ability to live alone. She found herself holding onto furniture as she walked through her own home. The long walks with Buster became short, hesitant trips around the block. The joy she took in her independence was replaced by a quiet, gnawing fear of falling again. The colonoscopy found nothing, but it cost her something invaluable: her sense of security, her trust in her own body. Her quality of life was significantly impacted, all for a routine screening that provided her with absolutely zero tangible benefit. Margaret's experience isn't just a sad, isolated story. It is a real-world demonstration of what happens when medical protocols are followed without being filtered through the longevity lens. It's a cautionary tale that highlights the very risks that our most respected medical bodies have been trying to warn us about for years. This isn't just my opinion. It is the official evidence-based consensus. In the United States, the gold standard for this type of guidance is the U.S. Preventative Services Task Force, or USPSTF. This is the independent panel of national experts that doctors look to for recommendations on preventative care. And their guidance on screening colonoscopies in older adults is crystal clear. For adults aged 76 to 85, they give it a C recommendation, which means the decision should be individualized, not automatic, based on a patient's overall health and prior screening history. For anyone over the age of 85, their guidance is even stronger, a D recommendation, meaning they actively recommend against screening. This isn't a uniquely American perspective. Similar expert bodies around the world, from the National Institute for Health and Care Excellence, NICE in the UK, to task forces in Canada, have drawn very similar conclusions. And why do all these independent groups, after reviewing all the available evidence, come to the same cautious conclusion? Because they are, in effect, applying the principles of the longevity lens. They have done the hard math. They recognize that for this age group, the principle of outliving the problem becomes a statistical probability. And they acknowledge the immense danger of reduced resilience, that the definite risks of the preparation and the procedure itself can cause profound harm. The risk of a fall, like the one Margaret experienced, is just one piece of the puzzle. There are other, less common risks that carry devastating consequences. And when we look at the hard numbers behind the single most feared complication of the procedure itself, you begin to understand just how high the stakes really are. The risks of the prep, dehydration, falls, electrolyte imbalances, are significant enough, but the procedure itself carries a small but very real risk of a catastrophic complication, a bowel perforation. This is when the instrument accidentally creates a tear in the wall of the colon. The odds are low, maybe around 1 in every 1,000 procedures. And this is where the system's logic can be so seductive and so dangerous. A doctor might say it's a 99.9% chance that everything will be fine, and that is statistically true. But the longevity lens forces us to ask a different question. It's not about the probability of the risk, it's about the magnitude of the consequences if you happen to be that one person. For a healthy 50-year-old, a perforation is a medical emergency. It means a rush to the operating room, surgery to repair the tear, and a week or two in the hospital. It's a serious, life-disrupting event, but one from which they are very likely to fully recover. Their resilience allows them to absorb that blow. Now, let's replay that same 1 in 1,000 event for an 85-year-old. The emergency surgery itself is vastly more dangerous. The anesthesia is a greater strain on the heart and brain. The recovery is brutal. They're at high risk for postoperative pneumonia, blood clots, or infections. A long hospital stay almost guarantees a significant loss of muscle mass and independence. Many will leave the hospital needing a temporary or even permanent colostomy bag. For that 85-year-old, a bowel perforation is not just a complication. It is often the end of their independent life. It is the very definition of a catastrophic event. This is the principle of reduced resilience in action. The consequences of that small statistical risk are magnified 100-fold. And when you weigh the definite, life-shattering impact of a potential complication against the uncertain benefit of finding a polyp that might never have caused harm, the math changes completely. So, does this mean we simply give up and ignore the real threat of colon cancer? Absolutely not. It means we need to be smarter. It means we must ask if there's a different path, a less invasive way to get the information we need without taking on these amplified risks. For many older adults who are at average risk, there are excellent, less invasive alternatives. Stool-based tests like the FIT test can be done in the privacy of your own home. They are highly effective at detecting the microscopic traces of blood that can be an early sign of cancer without requiring any dietary changes, sedation, or grueling prep. If the test is negative, you gain significant peace of mind. If it's positive, it doesn't automatically mean a colonoscopy is the next step. It means a thoughtful conversation with your doctor is. It allows for a targeted, personalized decision rather than a one-size-fits-all mandate. This whole approach is about shifting from a passive recipient of care to an active partner in it. It empowers you to ask your doctor the most important question of all, the core question of the longevity lens. Given my overall health, my age, and my personal history, does the potential benefit of this screening test truly outweigh the definite burden of the prep and the very real risks of the procedure? This principle of carefully weighing the harm of finding something against the benefit of treating it becomes even more complex and, frankly, more controversial when we move from looking for polyps in the colon to looking for cancer in other parts of the body. Because it forces us to confront one of modern medicine's most difficult hidden truths, that sometimes the most dangerous thing a screening test can do is find a cancer that never needed to be found at all. Now, this leads us to our second area, and it's perhaps the most emotionally charged of all, routine cancer screenings, like mammograms for breast cancer or PSA tests for prostate cancer. I need to be extremely clear here. The early detection of aggressive, fast-moving cancers is one of the great triumphs of modern medicine. It has saved countless lives, and absolutely nothing I'm about to say is meant to diminish that reality. But there is a shadow side to this success, a complicated, uncomfortable truth that the medical system has been slow to discuss with the public. It's the fact that our screening technology has become so powerful, it is now incredibly good at finding cancers that pose no real threat. It finds cancers that are so slow-growing or so non-aggressive that a person would have lived a full life and died from something else entirely, never even knowing it was there. This phenomenon has a name: overdiagnosis. It is the diagnosis of a disease that was never destined to cause symptoms or harm, and it is one of the most significant hidden harms of modern screening. Because the moment that diagnosis is made, the Cascade Effect kicks in with a vengeance. You can't unfind it. The label of cancer creates an immense pressure, both for the doctor and the patient, to act, to treat, to remove. And so people undergo surgery, radiation, and chemotherapy with all their life-altering side effects to treat a cancer that was, for all intents and purposes, harmless. They are harmed by the treatment of a disease that was never going to harm them. This idea is deeply counterintuitive. It cuts against the grain of everything we've been taught for 50 years, that finding cancer early is always better. To truly wrap our minds around how it's possible for a cancer to be essentially harmless and why our powerful tests are so good at finding these specific types, we need a simple way to visualize the problem. Think of all the cancers we could possibly find not as a single disease, but as different animals in a forest. Some cancers are like birds. They're incredibly aggressive and take flight early. By the time our current screening tests are sensitive enough to spot them, they've often already spread throughout the body. These are the tragic cases where, despite our best efforts at early detection, the outcome is poor. Our nets simply aren't designed to catch these birds in time. Then there are the rabbits. These are the cancers that screening was made for. They are moderately fast-growing and, if left alone, would absolutely cause harm or death. But our tests can catch them while they're still contained, and our treatments are effective. Finding a rabbit is a clear victory for medicine. This is the success story we all hear about, and it is a real and important one. But then there are the turtles. These cancers move so slowly, they might not even leave their own garden in a person's entire lifetime. They are biologically cancers, yes, but they are indolent, sleepy, and non-threatening. An 80-year-old man might have a turtle of a prostate cancer that would never have bothered him, and he'd eventually die peacefully at 92 of something else entirely. Here's the fundamental problem of modern screening. Our tests, our nets, are exquisitely good at catching turtles. They are far better at finding these slow-moving, harmless cancers than they are at finding the aggressive birds. And once we catch a turtle, the system almost never says, let's put it back in the garden and leave it alone. No. The moment the label cancer is attached, it creates a powerful emotional and medical momentum. We treat the turtle like it's a rabbit. We subject people to biopsies, surgeries, radiation, treatments with profound life-altering side effects to cure a cancer that was never a threat. We cause real, tangible harm in the present to prevent a theoretical harm in the future that was never going to happen. This isn't just a philosophical problem limited to cancer screening. This mindset, this systemic reflex to investigate every tiny abnormality, no matter how insignificant, poisons the entire medical process. It creates a culture of distraction, pulling doctors away from what is actually making a patient sick. And it is precisely this trap that was waiting for Arnold the moment he stepped into his doctor's office to talk about his swollen legs. And so, when Arnold finally walked into his doctor's office, he felt a sense of relief. He had his primary concern, his one clear question ready. What's happening with my legs? He sat on the exam table and waited for the doctor to look, to press on the swollen skin, to see the discoloration he saw every day. But the doctor, well-intentioned and following protocol, turned to the computer. A checklist appeared on the screen. Time for your annual blood work, Arnold. Let's get a full panel. The legs were noted in the chart, almost as an afterthought, under the heading Pitting Edema, but the focus of the visit quickly shifted to the screen, to the data points, to the preventative checklist. A few days later, the phone rang. It was the nurse from the clinic. The doctor had reviewed his blood work. Everything looks great, Arnold, except your thyroid level is just a little off. The doctor wants you to get an ultrasound of your neck, just to be safe. Suddenly, the heavy legs were the last thing on Arnold's mind. A new fear took over. Thyroid. Neck. He'd heard stories. The ultrasound was a cold, quiet procedure that found a tiny nodule just a few millimeters across. The radiologist's report called it suspicious in appearance and recommended a biopsy. This was the start of the cascade. The next 2 weeks were a blur of anxiety. He'd lie awake at night, his hand on his neck, imagining the worst. The biopsy itself was uncomfortable, a needle pressing into a deeply vulnerable part of his body. And then came the waiting. Every phone call made his heart leap. Finally, the results came back. The nodule was benign, a simple cyst. The wave of relief was immense, but it was followed by a slow, creeping frustration. In the 3 weeks the system had spent chasing the shadow, this harmless turtle in his thyroid, his real problem had gotten demonstrably worse. The swelling in his legs was now higher, reaching his knees. The skin was tighter, the heaviness more profound. He had spent weeks consumed with anxiety over a condition he didn't have, while the one that was actively diminishing his quality of life every single day was completely ignored. The system had successfully found nothing, at great emotional cost, and had left him sicker than when he started. Arnold's story is a perfect, frustrating example of overdiagnosis in action. The system did its job. It found something. But that something was irrelevant. It was noise, not signal. I need to pause here for a moment because I know this idea of overdiagnosis can be jarring. It goes against a lifetime of messaging that early detection is always best, so I'd like to check in with you. If this is the first time you're hearing about this concept in detail and it's surprising to you, just take a second and type the number 1 in the comments below. If this is something you've already suspected or maybe even experienced yourself, type a 2. There's no right or wrong answer. It just lets me know that this information is connecting, and it helps all of us see how common these experiences really are. This systemic habit of chasing down every tiny abnormality, every turtle, is what creates the perfect environment for the cascade effect to take hold. It primes the system to act first and ask questions later. And now we arrive at the third test on our list, the one I mentioned at the beginning, the routine cardiac stress test. This is the test that, with perfect tragic irony, was meant to check on Arnold's heart, but instead led him directly away from his real and far more urgent heart problem. Here's how it happened. With the thyroid scare having resolved into nothing, Arnold's doctor continued down his checklist. During the exam, he put a stethoscope to Arnold's chest and heard a faint heart murmur, an incredibly common finding in older adults, often with no clinical significance at all. But in a system primed to investigate, it's a trigger. "It's probably just age, Arnold," the doctor said reassuringly, "but I'd like to order a stress test, just to put our minds at ease." On the surface, this sounds like the most responsible thing a doctor could do. Find a potential blockage before it causes a heart attack. What could possibly be wrong with that? This is the critical turning point where the cascade effect gains an almost unstoppable momentum. Arnold's real problem, the congestive heart failure causing his legs to swell, is a plumbing pressure problem. A stress test is designed to look for a clogged pipe problem, a blockage in an artery. By ordering this test, the doctor wasn't just being distracted from the real issue, he was now actively hunting for a completely different one. The danger is that the hunt itself creates the problem. Here is the fundamental and frankly shocking disconnect between what the best evidence shows and what actually happens in clinics every single day. The assumption is that finding a blockage means you must fix it. But that is not what the science says. The landmark ischemia trial, a massive, multi-year study published in the prestigious New England Journal of Medicine, looked at this exact question. It took thousands of patients with stable heart disease, people just like Arnold who had blockages but were not actively having a heart attack, and divided them into two groups. One group received aggressive medical therapy alone, the best medications and lifestyle counseling. The other group received that same medical therapy plus an invasive procedure, like putting in a stent to open up the blockage. The results sent a shockwave through the cardiology community. Over a period of years, there was absolutely no difference between the two groups in the most important outcomes, heart attack or death. Let that sink in for a moment. A major invasive procedure, threading a catheter through the body and placing a metal scaffold inside an artery of the heart, offered no better protection from the events patients fear most than simply taking the right pills. The reason is that the kind of blockages a stress test typically finds are often old, hardened, stable plaques. They are the turtles of heart disease. Most heart attacks are actually caused by the rupture of newer, softer, more inflamed plaques that a stress test doesn't even see. The procedure fixes a stable problem that often wasn't the real threat, while leaving the more dangerous ones untouched. This is the kind of evidence that should fundamentally change medical practice. A halt would be compelled. It should make every doctor and patient stop and ask, "Are we sure this is necessary?" But this profound truth is often drowned out by the noise of the system. It gets lost in the immense momentum of the cascade effect. Once that stress test comes back positive, the pressure to act, to do something, becomes almost irresistible. The evidence is forgotten and the protocol takes over. And so for Arnold, that piece of paper from the stress test acts like a one-way ticket. It triggers the cascade effect with a vengeance. His doctor, seeing the positive result, immediately refers him to a cardiologist who schedules an angiogram to get a direct look at the arteries. The momentum is now undeniable. At each step, the question is no longer if they should proceed, but simply how and when. He finds himself in a cold, high-tech catheterization lab, lying on a narrow table under a massive X-ray machine. He's awake, but sedated. He feels the pressure as the catheter is threaded from his wrist up into his heart. On the screen, a ghostly black and white image appears, a roadmap of his own coronary arteries. The cardiologist points to a spot on the monitor. "There it is," he says, "a 70% blockage." In that room, at that moment, that number, 70%, feels like a verdict. It sounds severe. It sounds dangerous. The pressure to act is immense, not just from the doctor, but from the entire context of the situation. You don't go through all of this just to look. The implicit purpose of the procedure is to find something and fix it. Arnold, lying on the table, is asked to make a decision he is completely unprepared for. "We can put a stent in right now and open that up," the doctor advises. Of course he agrees. Who wouldn't? It sounds like he's dodging a bullet. A tiny mesh tube is deployed, propping the artery open. The procedure is a technical success. The 70% blockage is now 0%. Everyone in the room feels a sense of accomplishment. But it was the wrong problem. That 70% blockage was almost certainly a stable, hardened plaque, a turtle. It was a part of the landscape of his arteries, not the active threat everyone assumed it to be. The stent did absolutely nothing to address the actual reason he went to the doctor in the first place. His swollen legs, his growing fatigue, his shortness of breath when walking, these were not the signs of a clogged pipe. They were the classic signs of congestive heart failure, a plumbing pressure problem. His heart muscle was weakening, becoming an inefficient pump, causing fluid to back up in his system and pool in his legs. The stent didn't strengthen the pump. It didn't relieve the pressure. So Arnold leaves the hospital with a piece of metal in his heart. He's now on powerful lifelong blood thinners, which carry their own significant risk of bleeding. He has been subjected to an invasive procedure with all its inherent risks and endured the anxiety and recovery time, and yet his legs are still just as swollen. He still feels that profound, waterlogged heaviness with every step. His quality of life has not improved one bit. The system, in its relentless pursuit of a fixable number on a screen, had successfully performed a complex and elegant procedure that completely missed the point. This fixation on a single data point, a percentage of a blockage, a number on a lab report, is a recurring theme. It's a systemic blind spot that leads to interventions that look good on paper but do little to help the actual person. And this leads us to our fourth test, the routine bone density scan, or DEXA scan. Now, we must approach this topic with care because the fear it addresses is deeply personal and entirely valid. For many older adults, the single greatest threat to their independence is not cancer or heart disease, but a fall that leads to a broken hip. It is the event that can instantly change everything, transforming a vibrant, self-sufficient life into one of dependence and chronic pain. That fear is real, and the desire to prevent it is one of the most important goals in geriatric medicine. So let me be very clear, this is not a critique of the scan itself. The DEXA scan is a valuable tool. The problem, when viewed through the longevity lens, is not in the knowing, but in what we are conditioned to do with the knowledge. The scan gives us a number, a T-score, and for millions, that number falls into a gray area called osteopenia. Osteopenia is not a disease. It is a risk category. It simply means your bone density is lower than that of a young adult, which is a near universal part of the aging process. But in our medical system, this label has become a diagnosis in itself, a problem that demands a solution. And the solution, almost invariably, is a prescription for a powerful class of drugs. The Cascade Effect begins not with a fracture or with pain, but with a number on a page that medicalizes a normal stage of life. The patient, rightfully concerned about fractures, is told there's a pill that can help. It seems like a simple, logical step to protect against that catastrophic fall. The evidence shows these medications can indeed increase bone density scores, and the decision feels proactive and responsible. But it's here, in the very treatment designed to make bones stronger, that we find a disturbing and deeply ironic hidden risk. The solution itself carries a strange and cruel paradox, one that can lead to the very outcome everyone is so desperate to avoid. The primary medications doctors turn to are a class of drugs called bisphosphonates. You might recognize brand names like Fosamax, Actonel, or Boniva, and on paper, they appear to work. They can slow bone loss, they make the numbers on a DEXA scan look better, and they have been proven to reduce the risk of certain common osteoporotic fractures, particularly the painful compression fractures in the spine. But here is the cruel, ironic twist that is rarely discussed with the same level of emphasis. Long-term use of these very drugs is associated with a rare but catastrophic side effect known as an atypical femur fracture. Let me be very clear about what this means, because it is a profoundly different and more terrifying kind of break. This is not the fracture you get from a bad fall on an icy sidewalk. This is the femur, the largest and strongest bone in the human body, snapping, often with little to no trauma whatsoever. It can happen while you are simply walking across your living room, twisting to get out of a chair, or stepping off a curb. The very bone you were taking a powerful medication for years to protect can suddenly and completely fail under the most ordinary of stresses. The break is often described by orthopedic surgeons as a chalkstick fracture, a clean transverse snap straight across the bone shaft. The irony is almost too much to comprehend. The medication you diligently took every week to prevent a fracture from a fall can, in a terrible twist of fate, cause a fracture from just living your life. This knowledge places a patient in an impossible dilemma. It creates a complex web of fear where the supposed solution introduces a new, terrifying problem. It forces you to question the entire strategy. If the primary medical tool we have to strengthen bones comes with this paradoxical, life-altering risk, are we even focused on the right target? Perhaps the most effective way to prevent a broken hip has very little to do with the density of the bone itself. Perhaps we've been so focused on reinforcing the walls of the house that we've overlooked a far more powerful and much safer way to keep it from falling down in the first place. The single most effective way to prevent a fracture in older age, bar none, is to prevent the fall that causes it. This isn't just a comforting thought, it is a conclusion supported by overwhelming evidence. Major studies, like those published in the highly respected British Medical Journal, have consistently shown that targeted exercise programs can slash the rate of falls by a staggering 25 to 50%. That is a risk reduction that no medication on the market can claim to match. And we're not talking about running marathons or becoming a power lifter. We are talking about simple, accessible, and consistent practices that can be integrated into daily life. Gentle yet powerful movements like Tai Chi, which has been proven time and again to dramatically improve balance and body awareness. Specific physiotherapy exercises designed to strengthen the leg, hip, and core muscles, the very muscles that act as your body's emergency brakes, catching you when you stumble. It can be as simple as practicing standing on one foot while you wait for the kettle to boil, or joining a local balance class. This represents a profound shift in the locus of control. It moves the power from a prescription pad and into your own hands. It reframes the problem from a chemical deficiency that needs a drug to a physical skill that can be learned and improved. And unlike a pill with a list of frightening potential side effects, the side effects of strength and balance training are all profoundly positive: more energy, greater confidence, and a more robust sense of independence. It's an intervention that doesn't just protect you from a catastrophic event, it actively enhances your quality of life every single day. This pattern, where a seemingly straightforward medical solution hides a dangerous paradox, is a recurring theme. The bisphosphonate that can cause the very fracture it's meant to prevent is a perfect example. But nowhere is this paradox more immediate, more dangerous, and more of a life-or-death gamble than in our fifth and final test. This brings us to the surgical catch-22 I promised you at the beginning. It involves a routine scan of the arteries in your neck, and it can lead to a decision where the cure itself carries a higher upfront risk of causing the very disaster it's meant to prevent. This is the one that is so quietly consequential, so counterintuitive, that it often traps patients and doctors alike in a logic that can lead directly to catastrophe. We are talking about screening for carotid artery stenosis, blockages in the two major arteries in your neck that supply blood to the brain, in people who have no symptoms whatsoever. The cascade here almost always begins with an act of diligent, old-fashioned doctoring. Your physician listens to your neck with a stethoscope and hears a faint whooshing sound called a bruit. It's the sound of turbulent blood flow. In the interest of being thorough, they order a simple, painless neck ultrasound, just to see what's going on. It feels like the most responsible, prudent step imaginable. Find a potential stroke before it ever happens. But what most people don't realize is that this single, seemingly harmless test places them at the entrance to a high-stakes medical paradox. Because if that ultrasound reveals a significant blockage in someone who has never had a warning sign, it forces an almost impossible choice. It presents a dilemma so fraught with risk that the leading medical authorities, like the US, Preventative Services Task Force, have long recommended against doing this screening in the first place. Because once you find that blockage, you are faced with a terrible choice, a true catch-22. Here's the choice you are given. Option 1. You can leave the blockage alone, knowing that it carries a small statistical risk of causing a stroke at some point in the future. Option 2, you can choose to fix it with a major surgery called a carotid endarterectomy, where a surgeon cuts open your neck, slices into the artery, and physically scrapes out the plaque. And this is where the paradox slams shut, creating a devastating gamble. The surgery itself, the very procedure intended to prevent a stroke, carries an immediate, upfront risk of causing a stroke or death right there, during or shortly after the operation. Here's the key fact you must understand. Major studies, like the asymptomatic carotid surgery trial, have shown that the risk of the surgery itself causing a stroke or death is between 2 and 3%. Now, compare that to the annual risk of stroke from the blockage if you just leave it alone, which for many people is less than 1% per year. You are being asked to accept a definite 2 to 3% chance of an immediate catastrophe in order to prevent a less than 1% chance of a future one. The cure is statistically more dangerous than the disease. For an older adult whose resilience is already reduced, the risks of major neck surgery and general anesthesia are even higher, making the gamble even worse. This is precisely why the U.S. Preventative Services Task Force recommends against this type of screening in the general population. They recognize that the test itself doesn't cause harm, it's the dangerous cascade it triggers that does. It forces good people and good doctors into an impossible corner, where the logical-sounding path of fixing the problem is actually the riskier choice. And this isn't some rare academic dilemma. It's a choice that thousands of people are forced to make every single year, pushed onto a surgical conveyor belt by a screening test that authorities advise against. The problem isn't just one person's story, it's a systemic failure. Now, this is the point in our journey where I would normally tell you another story. I could introduce you to a patient, give them a name, and walk you through the harrowing experience of how a routine sound heard through a stethoscope led them to that fateful choice, and for some, to a devastating, life-altering stroke on the operating table. But for this final example, I'm not going to do that. And the reason is simple. To reduce what happens next to a single personal anecdote would be a profound disservice to the scale of this problem. This isn't the story of one unlucky person. It is the reality for thousands of people like Arnold and Margaret every single year who are guided onto this surgical path based on a screening test that the most respected authorities actively recommend against. This isn't about one bad doctor making one bad call. It is about a systemic momentum. It is the Cascade Effect in its purest and most dangerous form, a sequence of seemingly logical steps that, once initiated, becomes almost impossible to stop. The system is designed to find and to fix, and it does so with incredible efficiency. But it has no built-in mechanism to pause and ask, should we have looked in the first place? The momentum of the cascade simply overpowers the evidence. It is a system that often cannot stop itself, and that realization brings us to the most critical question of all. So, if the system itself has this powerful built-in momentum, how do you as an individual stand your ground? How do you protect yourself from being swept away by this cascade? More importantly, how do you ensure that the care you receive is truly aligned with your life, your values, and your goals? The answer is not to reject the system, but to learn how to navigate it with skill. At the beginning of this video, I promised you a tool to do exactly that. And now, we are going to put that tool in your hands. It's a simple but powerful framework that I call the 5 empowering questions. Think of these questions as a script you can take with you into your next doctor's appointment. Write them down on a piece of paper, put them in the Notes app on your phone, have them ready. They're designed to shift the dynamic of the conversation, moving you from being a passive recipient of a protocol to an active, engaged partner in your own care. They are polite, they are respectful, but they are also firm. They require your doctor to pause, to move past the checklist, and to think specifically about you. These 5 questions are your brakes. They are how you stop the conveyor belt and ensure every decision is filtered through the one thing that truly matters, your quality of life. Let's go through them now, one by one. Here's the first question, and it is the foundation for all the others. Before you agree to anything, you must ask, 1. Why are we doing this test? What specific question are we hoping to answer? This question is deceptively simple, but it is incredibly powerful. It forces a conversation to move beyond vague justifications like it's routine or it's just part of the protocol for someone your age. Those are not reasons, they are habits. This question respectfully demands a clear, clinical purpose. Is the doctor trying to confirm a specific suspicion they have based on your symptoms? Are they trying to definitively rule out a dangerous condition? What is the precise medical mystery that this test is intended to solve? Answering this forces clarity. For Arnold, if his doctor had been asked this about the thyroid ultrasound, the answer would have been, we're trying to understand why a single blood marker is slightly off range. That clear purpose might have led to a less aggressive next step, like simply rechecking the blood test in a few months, rather than immediately launching into the cascade of scans and biopsies. This question cuts through medical inertia and ensures that you are not on a fishing expedition, but on a targeted search for a meaningful answer. This leads directly to the second question, which tests the practical value of that answer. 2. What will we do differently based on the results? If it's positive, what is the plan? And if it's negative, what is the plan? This is the ultimate test of clinical utility. If the answer to this question is, well, we wouldn't really change our plan either way, then you have to seriously question the necessity of the test. A test that doesn't change the management plan is not a medical tool. It's a source of anxiety. It's the difference between using a map to decide which road to take versus just collecting maps for the sake of having them. For a patient like Margaret who had no symptoms, the plan before her colonoscopy was to continue living her life. After her clean result, the plan was to continue living her life. The test provided no new actionable information, but it came at a tremendous cost to her quality of life. This question ensures that any test you undergo is a genuine fork in the road, a decision point that will actually alter your path forward, rather than a detour that leads you right back to where you started, only more tired and shaken from the journey. The third question directly addresses the hidden danger we have spent this entire video uncovering. You must look your doctor in the eye and ask, 3. What are the risks of the test itself? And by that, I don't just mean the immediate risks of the procedure, but the risk of it starting a cascade of more tests and interventions. This question names the monster. It demonstrates that you are a sophisticated, informed patient who understands the concept of the slippery slope. It forces the conversation to move beyond the surgeon's 1 in 1,000 statistic for a perforation and to acknowledge the much, much higher probability of an ambiguous finding. It's the suspicious but benign nodule, the borderline reading, the minor abnormality that once found cannot be unfound. This question makes the invisible risk of the cascade effect a visible, tangible part of the decision-making process. It acknowledges that the single greatest harm of many tests is not the test itself, but the unstoppable momentum it creates. By asking this, you are inviting your doctor to consider the entire journey, not just the first step. Fourth, you always want to look for the path of least resistance and least harm. 4. Are there less invasive alternatives that we could consider first? This question challenges the system's default setting, which often leaps to the most technologically advanced and invasive option first. It actively searches for an off-ramp from the medical highway. For many people concerned about colon cancer, it's about starting with a non-invasive stool test. For those worried about bone health, it could be about prioritizing a consultation with a physical therapist about fall prevention before starting a powerful drug. This question signals to your doctor that you are not risk-averse, but you are harm-averse. You want the wisest path, not necessarily the most aggressive one. It recenters the goal on solving the problem in the simplest, safest way possible, preserving your body's resilience rather than spending it on procedures that may not be necessary. And finally, the most important question of all, the one that anchors every decision in the philosophy of the longevity lens. 5. How will this test and any potential treatment that follows affect my quality of life? This question brings the entire, often abstract medical conversation back down to earth, back to your real, lived, day-to-day experience. It moves the goalposts from the doctor's world of lab values and percentages to your world of energy, independence, and peace of mind. Will the side effects of this treatment make me too tired to enjoy my grandchildren? Will the recovery from this procedure mean I can't tend to my garden for a month? Will this new medication cause brain fog that takes away the joy I get from reading? This is the ultimate bottom line. It forces the medical plan to serve your life plan, and not the other way around. It's the question that could have saved Arnold from a useless stent and Margaret from a devastating fall. Now, I know what you might be thinking. Walking into a doctor's office with a list of 5 challenging questions can feel intimidating. You might worry about being perceived as a difficult patient, or as someone who's questioning your doctor's expertise. That is a legitimate concern, but the way your doctor responds to these questions is in itself perhaps the most important diagnostic test of all. Let me be absolutely clear about the reaction you should expect, and the reaction you should hope for. A good doctor, a truly great physician, will welcome these questions. They won't see it as a challenge to their authority. They will see it as an invitation to a partnership. They will recognize that you are an engaged, thoughtful advocate for your own health, which makes their job of helping you not harder, but easier. A good doctor wants to have this dialogue because it ensures the treatment plan aligns with your life, which is the ultimate goal of all good medicine. However, if a doctor becomes dismissive, if they wave off your questions with a paternalistic "don't you worry about that," or if they seem irritated that you're interrupting their workflow, that is a red flag. It is the most important test result of the day. It doesn't necessarily mean they're a bad doctor, but it may mean they're a doctor who is trapped in the system's momentum, following a protocol rather than thinking about you as an individual. It suggests they are more focused on the checklist than on the person sitting in front of them. This isn't about being confrontational. It's about seeking collaboration. It's about ensuring your voice is heard in decisions about your own body and your own life. This entire approach, the shift from passive patient to active partner, ultimately brings us full circle, back to Arnold. Because his journey reveals the profound difference between a system that treats tests and a doctor who treats a person. And in that difference lies the final, most important lesson about the true meaning of health. After the ordeal with the stent, Arnold was left feeling lost. He had been through the very heart of the medical machine, subjected to its most advanced technology, and yet he was no better off. His legs were still heavy, his breath still short, so he sought a second opinion, this time with a geriatrician, a specialist in the complex health of older adults. And the first thing she did was something revolutionary. Nothing. She didn't order a test. She didn't turn to a computer. She pulled a chair up close, looked him in the eye, and said, "Arnold, tell me everything. Start from the beginning." For 20 minutes, she just listened, letting his story unfold without interruption. The socks, the shiny skin, the heaviness, the frustration of being ignored. Only then did she gently lift his legs and look at them closely. She ran her fingers over the tight, discolored skin. She pressed her thumb firmly into the swelling above his ankle and watched with a trained, patient eye as the deep pit remained. In that quiet moment of observation, she saw what all the scans and tests had missed. She saw the full picture. "Arnold," she said softly, "this isn't about your thyroid, and it wasn't about that blockage. Your heart is a tired pump, and it's struggling to keep up. The fluid is backing up. This is congestive heart failure." The diagnosis was based not on a number from a machine, but on classic clinical signs that physicians have recognized for 100 years. The treatment was not an invasive procedure, but a simple targeted medication, a diuretic, a water pill, to help his body relieve the pressure. Within a week, the change was astonishing. The swelling began to subside. He could see the bones in his ankles again. Within a month, he could climb the stairs without pausing for breath. The heaviness was gone. He felt lighter, not just in his legs, but in his spirit. His quality of life was dramatically, unmistakably better. Arnold's journey reveals the fundamental choice we face. There's a difference between medicine that finds things and medicine that helps you live well. The first path is a relentless hunt for imperfection, a cascade of interventions that can leave you sicker than you started. The second is a partnership. It understands that the goal after 60 is not to achieve biological perfection, but to preserve the joy, function, and independence that make life worth living. It is the application of wisdom, not just technology. It is about remembering that true healthcare is not about what we find in the body, but about how we care for the person. If this approach to health, this philosophy of using the longevity lens to put your quality of life at the very center of every medical decision, resonates with you, then I invite you to subscribe to Keystone Health. My goal here is not to give you simple answers, but to equip you with the right questions. Each week, we break down another complex medical topic, looking at the hard evidence and translating it into practical wisdom you can use to protect yourself and your loved ones from the system's momentum. We explore the evidence behind common treatments, dissect new studies, and provide clear frameworks, all designed to do one thing: empower you to be a confident, active partner in your own care. By clicking that subscribe button and turning on notifications, you're not just joining a channel. You are making a clear statement that you value wisdom over protocol and quality of life over quantity of tests. You are joining a growing community of people committed to navigating their health with clarity and courage. And that community is built on sharing what we learn. The most powerful way to solidify the knowledge you've gained today is to engage with it, and there's one final step we can take together to do just that. Now, I invite you to go back to the comments. We began by asking if you've ever felt that the numbers on a chart mattered more than you did. Let's end by turning that feeling into action. I want you to share one thing. Either the single most surprising insight you learned today, or the one empowering question that you will now carry with you into every future medical appointment. Please take a moment to do this, because your comment is more than just a comment. It is an act of service. It becomes a permanent part of a library of shared wisdom for this community. Your chosen question might be the exact phrase someone else has been struggling to find, the one that gives them the courage to speak up. It could be the spark that helps another person, a complete stranger, avoid a dangerous cascade, just like the one Arnold experienced. Scrolling through the comments on a Keystone Health video is unlike almost anywhere else. It is a powerful, real-time testament to the strength of a community committed to a wiser path. It is tangible proof that thousands of people are walking this journey together, a journey guided by evidence, centered on quality of life, and grounded in mutual support. It is the place where we move from being passive patients in a system to becoming active partners in our own health. Your voice is a vital part of that transition. Thank you for sharing it, and thank you for being here. After seeing how a simple leg observation could have prevented a dangerous cascade, what's one area of your health where you'll now question the standard approach? Answer in the comments below. I read and reply to every single one. This pattern of missing the big picture extends to things we take daily. In our next video, we expose the #1 supplement for bone health that may actually be harming you. Subscribe and turn on notifications so you don't miss the truth. Like and share this with someone who needs to know the full picture.